welcome to Australia's first roundtable discussion on shockwave therapy. For those who don't receive my emails, I'm Danielle and I'm the Education Manager at EMS. And I have the privilege of moderating tonight's roundtable and introducing our brilliant thought leaders and shockwave experts. First up, hailing from Melbourne, and do you want to give a bit of a wave, is podiatrist Dr. James Ferry. Dr. Ferry has special interests in regenerative medicine and sonography and has postgrad training from the Interventional Orthobiologics Foundation. And hopefully I pronounced that correctly, James, because it was a bit of a mouthful. Our next distinguished expert and published author on back pain is chiropractor Dr. Adam Gavin. Dr. Adam Gavin, thank you for the wave, Adam, has a special interest in sports rehabilitation and is one of the most experienced full body certified active release techniques providers in Australia. And also hailing from Sydney and in lockdown is physiotherapist Marcus Sabella. Give it a bit of a wave, Marcus, thank you. Marcus has a master's in sports and MSK and has travelled Australia and the world as a physio, most recently working with the Cirque du Soleil for 8 years. So let's give all of our speakers a warm welcome. Now, the purpose of tonight's roundtable is to give you, the participants, the opportunity to ask questions throughout the event. So please place any of your questions into the chat or the Q&A. And I'm going to kick off with our first question. So James, you're the first person in my screen there. So the first question is to you. Why and how did you integrate shockwave therapy into your practice?
Thanks, Danny. Look, I was lucky enough when I first left uni as a new graduate and was working down in rural Victoria in Gippsland. We were one of the first clinics in Australia to purchase a shockwave machine. So I was lucky enough from sort of the, from my being a new grad podiatrist to have experience using shockwave. And as I've more recently sort of now relocated back in Metro Melbourne and also started my own clinic a few years ago, it was sort of second nature because shockwave really become quite integral to how I treat. We see so many, as a podiatrist, we see so many tendinopathies, plantar fasciopathies, so many chronic conditions that it's a non-invasive, effective tool at my disposal. So when it was sort of second nature. So when I started my own practice, it was really not an if I'd get shockwave, but really it was how I practiced now because I'd used it for so long. So the integration in terms of where I fit it into treatments, I really use it as effectively for really chronic injuries. It sort of fits as a bit of a reset for those injuries. So, and that's a bit how I describe it to patients often. When we've got when the computer is not working properly, you try a few different things. Sometimes you just have to hit the reboot button on it. And shockwave can be a little bit the same. Sometimes as clinicians, we try a few different things. We try some exercise, we try strapping, we try an orthotic, we try various interventions. And in some cases, they work for some patients. And in some patients, they don't work and the patient sort of fails to progress. And I think that's where shockwave is used. So I use it in conjunction with a lot of other therapy. But it also as a standalone treatment. And I think as well, sometimes patients come in there with their own preconceived ideas of and I have patients that, we work as a podiatrist and they may come in and they just say, look, I just don't want orthotics. And rather than fighting that uphill battle some of the time, shockwave gives you another tool in the system. And the more tools you have at your disposal, I think the more dynamic you can be as a practitioner. If something's not working, and I think patients keep you honest, you can't be too dogmatic in one approach. So, I'm a believer in a lot of different things. For a lot of patients, sometimes it's finding the right combination of those things. And I think shockwave works really well. So to me, it's second nature in integrating into the practice. Yeah.
I like that reset analogy there. Adam, has that been similar integration at your practices?
Yeah, it's very similar kind of approach that I have. I use I'm multi-modality, so I do some soft tissue work such as A or T. I do some joint adjustments, mobilizations, instrument-assisted soft tissue mobilization. I even do some dry needling and some kinesiotaping. So it's just, again, it's another tool in the toolbox, and it's a very useful tool. And like I explained to my patients, just like a carpenter, when he encounters a screw, he selects the appropriate tool from his toolbox. He'll get a screwdriver. He wouldn't take out a hammer to use on that screw because it's the inappropriate tool for the job. So it's more about having all these tools at your disposal for when you encounter those specific jobs that would benefit most from it.
Another analogy, I love it. That's the easiest way to explain to patients. Marcus, any further additions on your end, how you've integrated it?
Yeah, no, I think that's covered a lot of aspects. It's really been a highly beneficial adjunct to my therapy. I think we do a lot of similar things within the realms of physio and chiro and the manipulation and mobilization sense. I think I've found I'm also use a lot of dry needling and have always in the past. And so I was trying to integrate it around that as well and have that secondary way of approaching soft tissue. It actually helped make my practice a bit faster as well, I have to say. That's one of the things that stood out to me, is that I was able to access a lot more area far quicker than if I was needling. And there's still times when I do use no dry needling. I might go back to that as a modality. But the Shockwave allows me to get to more areas, I'd say, during a session, and possibly has made my sessions a little bit faster as well.
So are you seeing more patients throughout the day? Is that the case? Or you say faster, or?
Yeah, I'd say I could probably see a few more patients in the day because I can cover more surface area, and I tend to get a lot of bang for my buck from the Shockwave. You get a lot of release very quickly if it's used carefully. As I said, you can cover more area than just with dry needling alone, and it can be an assisted tool with soft tissue. So I found it really good in my clinic to not always be using my hands, for example, and that has made a big difference. And it also, if you use it carefully, and this will be touched on later, I guess, you can often use it before you do your soft tissue, so it's not as difficult. So, but I'm sure we'll come to that later on. But yeah, as an adjunctive tool, it's been amazing. It's just added a different dimension to my practice and allowed me to get more done in a shorter period of time.
Perfect. Thank you, Marcus. A big question that we get from a lot of prospective Shockwave customers and existing Shockwave customers is, how do you bill for Shockwave? James, can you take us through a little bit about that on your end?
So, look, it's probably a bit different. I think when it's your going out into business has been a bit of a new venture over the past few years, and I think when it's your own money on the chopping board, it really does keep you honest to a degree. I think in terms of billing for it, the way I tend to work as a clinic is I see my consultation fee as being really the cost of doing business. So it's the cost of a receptionist, it's the cost of the premises, and it's the cost of my time. So my appointments are sort of billed as in time fragments. And then any additional treatment that costs me money, whether it's a Shockwave investment, whether it's an injection, whether it's an orthotic, whatever, that has to also return some, it has to be basically on-sold to the patient. Otherwise, I'm cutting into that bottom line, which is my consultation fee. So as a bit of a, I think in terms of the range that people are there are people that don't charge any additional fee for Shockwave, and there are clinics that charge $100. I know a sports medicine clinic, they charge $90. I charge around that realm. I charge the higher end of it. And this is a little bit of a learning curve. So when I first introduced Shockwave into my practice, I didn't really have a great understanding of how to properly price or bill that. So I just chose a number that I thought was sort of ballpark figure average of what I thought other people were charging. And then part of it comes down to it's a significant investment. and that is money that's coming out of the clinic. So it has to provide a return, and it's my own money. So after the first year, what I did was I basically did an analysis. I just brought up the billing data and looked at how much revenue did that Shockwave unit bring in for the year versus how much did it cost me to run. And in that first year, I actually made a loss on it. So I had to reprice it. And I significantly increased the price of Shockwave. And I redid that analysis last year. Just at the end of the financial year. And that Shockwave unit went from basically I made about a 50% loss the first year that I introduced it, to last year it made it went to a 200-fold increase in what it cost me to have the unit there. So part of it is that pricing. And I think as well, when the way I see it as well, to a degree, and I don't think there's necessarily a right or a wrong way. For each clinic, there is going to be a different approach, and they've got slightly different business models and the way it works. That's how it works for me. I think as well, if you underprice something, as humans, we use price as a bit of a metric for value to a degree. And if you underprice something, you, to a degree, infer that it's not of very high value to the patient. And the reality is that it's a significant investment for your business. And if I'm providing that service at really what it's below what it's costing me to have the Shockwave in the unit, then it's not making my business more sustainable. So I don't know if there's and there's so many different approaches, and I know many other clinic owners approach it in a different way, but that's how I approach it. And the change from altering my billing from low cost to a higher cost, the number of Shockwave sessions that I did went up significantly higher as well. So the whole, when it comes to healthcare, I think our patients are not necessarily, like when I make healthcare decisions, looking for a dentist and things like that, I'm not making necessarily a price sensitive one. I'm not looking for the cheapest provider out there. There's other things that I think are of more value to me in that thing. So I'm not going out there looking for the cheapest dentist or the cheapest physio. I'm looking for one who's recommended. I'm looking for one who has good experience. I'm looking for a clinic that I like. I'm looking for all of those things. So that's where I think, I don't want to undersell it's a powerful tool, Shockwave, in your practice, and I don't want to underprice it for that reason.
No, thank you, James. I think highlighting there the importance of putting together a business plan and looking at your pricing models is important. Adam, do you do things a little bit different, or you're similarly put together a business plan?
Yeah, well, when I first got it, I just purchased my own device. I went out on my own in February 2020, just before the pandemic came in, which was great timing on my part. But yeah, so I bought a device then, and basically the clinic I worked at before, we actually didn't charge any extra fees for the Shockwave treatment. We were going to, and then my boss just simply didn't get around to doing it. And then once we had been treating people for a few months, it was a bit hard to start to introduce a cost to it. So when I started it, I simply just wanted to cover my costs. So I put it at $15 on top of my consult. And funny enough, when we started discussing this topic about a month or two ago, I kind of revisited my finances and stuff, and I decided to increase it up to $25 on additional on top of my standard consult, which is $80 for 20 minutes. So I was a bit worried that some patients would complain about it, but really none of them have. They go, oh, okay, it hasn't been a big deal, and it's almost doubled the income for the year. I was making just over $3,000 a year with the $15 charge, and now I'm making over $6,000 with the just by increasing it $10. So it was a smart decision, and it hasn't negatively affected the numbers at all. It's actually increased my revenue. So it was a good way to do it.
Thank you, Adam. Marcus, is you price it similarly to Adam?
Yeah, pretty similar to Adam. I haven't. I've sort of kept it at that mark, and I haven't experienced any difference in people coming in for it. In fact, I get more people who are looking for it. So I'm very similar. I'm going last all the time, but my answers
that's okay. I'm asking you the next question next.
It's all good.
There is a question from Caitlin here, so I'd like to ask you first, Marcus. Do you package the price, like X number of sessions paid up front, or reduced rate or anything?
Yeah, I don't, only because I go organically about how much they're going to need. I don't know for certain how many sessions I'm going to do. I don't really work that way. I sort of see how we're going. I try to plan out a bit for them so they know what's going to be coming financially. So I always say I'm going to do 3 sessions up front. This is how we're going to play it. We're going to do one a week apart for pretty much every condition I use it for. That's how it is. And then from there on, it really depends on how they've responded to it or what angle I choose. So I might choose to do something different. So, but yeah, that's why I can't really package it, because it is so individualized to every person.
No, makes sense. Personalized service. James, there is a question for you here. Do you charge per foot or do you charge a flat fee?
So no, I do. I charge depending on like a site, effectively. So the cost of doing it say a second site. So if I'm doing a heel, I'm pretty much, it's covering all of that. If I'm doing 2, they've got Achilles tendinopathy in both feet, I do charge an additional amount on top of that. And it's basically probably about 40% the cost of the first one on top. And I agree with Marcus. I think I've sort of thought about packaging it, but I don't like. I'm sort of try to be, as a clinician, it's hard, and I don't want to do the sales type thing. It's this is a therapy that we're going to use, and I give them a range, and I don't try to. For me, it just doesn't work with my business model. I think in trying to package it and giving discounts and stuff like that. It's not the sort of it's not really the message that I particularly want to do, but it does work for some people. And I think there are different ways. There are ways you could package, treatment together, but I think I prefer to just sort of keep it that more organic, and it really depends on what the patient needs. I generally tell them, I pretty much say, look, 4 sessions is the most common that I do. So I tell them, look, it's pretty much 4 sessions. For most treatments, it's 4. And then, if it's really chronic, I'll tell them, look, it might be sort of, 5, 6. 6 is like max. I think after 6 sessions for most sort of tendinopathy type things, you sort of max out a little bit in terms of there's no more, the return on your, I just don't know if you get that much more advantage, in that first 4 sessions. You almost need to give the tissue a bit of time to heal. And then I'll often do top-up sessions if the patient needs it, rather than doing like a long series of sessions in that first one.
That makes sense. That makes sense. Adam, there's a question here. How is the cost broken down if you shock 3 spots for an Achilles? I'm not sure if that's something that can be addressed, that question.
So, well, sort of, I keep it as a site. So it's not that, so I'd say that, treating the Achilles tendon, I'd say like that's one site. If I'm treating the left and the right Achilles tendon, I sort of see it as 2 different sites. So, by actually, because it's already billed reasonably, it's if I need to do an extra 1,000 shocks or whatever, I don't really care about that. It's more so, if I'm doing 2 different legs or something like that, or I'm doing, that's how I tend to break it up. Not that I'm doing 2 sites on the same Achilles tendon.
No. Just seeing there might be another question here. Do any of you use a specific item code in addition to your consult?
Yeah, so with the podiatry one, it's a 145. It doesn't really provide much of a rebate. So when patients ask, is this covered by private health? I say, look, it does have an item number, but that item number is like electrophysical therapy. So it was really set up, for therapeutic ultrasound and things like that. And the private healthcare companies have lost quite a bit of interest in those. It works well for patients that are, some of the funds now, you just choose an amount that you're covered for. So you might have podiatry cover, physio, chiro, and you get a limit of $400, and they will cover, up to 50% of your consult fee. And those private healthcare companies don't care whether it's a 145 or whatever item number. It's like, just once you've maxed out, they'll pay 50% of the bill. And once it's hit that 400, they won't pay any more. So those ones work really well for Shockwave patients because it's really factored in there. But in general, I don't even tell patients to necessarily check the item number with their private healthcare fund, because it's either a very small amount or it's not covered.
Marcus, do you have anything further to add on there's a few questions that are coming here and about item codes?
No, we don't. I'm not aware of us as physios using different codes other than the standard treatment code. So nothing additional that I am aware of that we can cover or access for that.
There's a very good question here, actually, because I'd like to talk a little bit about managing patient expectations in regards to what shockwave therapy here is. And there's a question here they'd like to hear your elevator pitch to clients as to what shockwave therapy is and how it works. Marcus, I'll start with you with that one.
You're going to start with me. That's the most technical question of the lot. I really say to them that it is, what we're doing with Shockwave is we're starting a process of healing. I try not to make it too complicated for them, because I think we can branch off into all the different things that are happening chemically. But what they need to know, and I also am going to tie this into the whole pain thing, how do we sell pain to the patient, is that we're creating a reaction within the body. And that reaction is, it's going to hurt. Like Shockwave hurts. It doesn't have to be that painful. You can make it very, very light. So you can start very, very gently and build up. So it allows that person the chance to get used to the feeling, because it is a very unique feeling. If anyone hasn't tried it, it is a prickly, electric-y sort of feeling. And some people have a very sensitized nervous system, and you need to build them up slowly. So I just basically say to them, look, we're going to start a process of treatment here that involves creating a change in your system. And that change will will basically allow us to do more with your body. And that might mean you get to do more exercise, or I can give you a more specific rehab, or I might be able to do more mobilization or manipulation with you after it's done, or there's a variety of things that might come from it. But it's a way of letting them know that there's going to be a new stimulus added to the area that, and a lot of them never have had it before. So there's a whole other set of, occurrences that happen there around placebo and other things that I think we need to be aware of. So there's just an awareness that there's going to be a change to the system that will then allow me to access their body in another way, and for them to access parts of their motor control and activity system in another way. So that's pretty much my spiel. I know there are some other practitioners who use it, talk about breaking down scar tissue and getting inflammation going and things like that. I think there's for me, it's just about, as I said, letting the patient know there's going to be something that's being done to them that's quite involving and quite full on, and that's going to allow them to do more with their system afterward.
Adam, obviously, shock, sometimes when patients first see that word, they think of electrotherapy. Has that been the case on your end, and how are you explaining what shockwave therapy is?
Yeah, I don't think too many people have negative connotations to it. They're more kind of inquisitive about it, because usually when you're introducing it, I usually introduce it to them when the machine's in the room next to them, so they're like it's shiny and new, and it lights up and makes noise, and I think as human beings we're all kind of inquisitive to a degree. So I just kind of explain to them what it does and the theoretical model of how it works obviously I try and use layman terms rather than go through all the pathology and physiology and biology of how it works, because you tend to lose them if you do all that. So I just tell people, similar to what Marcus was explaining, is you just explain that it causes changes to the tissue we apply it on to cause healing. We're stimulating your body to heal, and that's kind of it. And it's you have to explain to them. I always explain to them that it is painful. I almost set the expectation that it's going to be more painful than what they expect, so that when you do apply it, if it's as painful as you explained, they go, oh well, he said it would be like that. If it's less painful than what I explained, then they go, oh, that's easy. That's hardly anything. Is that all? And that's usually the response. But I also put it on a very low setting on the first treatment. I always tell, when I teach seminars on how to use the device, I always tell people, go easy on patients on the first visit. Because if you're too aggressive and you set the bar pressure too high, it hurts. And even if you give them a good result, even if they feel better, they're going to still remember that it hurt. It sucked having that done. And they might not come back. I had patients early on where I actually did that, and I rang them up and I'm like, how come you didn't come back? And they're like, that was really painful and I don't deal with pain very well. Even though they were feeling better a few days after the treatment. So you have to set that expectation to a degree without being like, oh, this is going to kill and you're going to be in so much pain. I also tell them before I do it, I said that it's based on your pain threshold. So using like the visual analog scale, if it's a 0 being no pain at all, 10 being the worst pain you've ever experienced, I don't want to exceed a 7. So if I get to it, if I'm doing an area and someone says that's a 7, that's the ceiling. If they say it's an 8, I'll either turn it down or I'll move to a different location until it settles down a little bit. Usually I don't start with the most painful area. I start a little distal to that and I work up towards it, because you're going to get the analgesic effect of the treatment more distal, which will cause a decrease in the pain in that painful area. So it's just a smart way of doing it rather than just get in there and say, suck it up.
And Adam, you've had quite a number of referrals from patients, correct? After they've experienced it and were healed from their pain. I believe that there was one lady who has recommended over 10 people to your practice after receiving a treatment from you.
Yeah. Well, that's the other good thing about it is you can have really good success rates for things that are often difficult for a lot of other practitioners to remedy. Like, I was actually kind of surprised when some patients came in and they were like, oh, I've seen all these different, and she was one of them. She had spent over $10,000 in 2 years, had seen 5 physios, 2 sports meds, and an orthopedic surgeon before she had seen me. And so when I told her, look, I can probably get this right in, maybe 3 months, she just said, yeah, right. And she actually hadn't visited her daughter who lived in Hong Kong for over 2 years because she couldn't walk more than like 100 meters without excruciating pain. So after 10 weeks, I think I had her on a plane to Hong Kong. And so that's, for people, that was a big deal for her. She hadn't seen her daughter or her grandchild for over 2 years because of her debilitating plantar fasciopathy. And I was able to help her with that and get her on a plane.
Fantastic results. Fantastic.
And like you said, she told all her friends and family to come see me. Even like strangers, she tells strangers if they mention they have foot pain or plantar fasciopathy, she goes, you have to go see Adam. He'll sort you out.
That's the best referral, isn't it? James, there's a question here. that I should have addressed at the beginning, but the question is, are you using focused or radio shockwave, and which shockwave? James, do you want to, you're all using the same device, so you want to briefly mention what device you're using?
Yeah, so I've got a one of the older classics, EMS Dollar class. I use radial. I think I use the Evo handle, and I also have a power handle as well. I think when you go through and do a literature review, when it comes to most of the conditions that I treat, the evidence seems to be at moderate, moderate energy radial shockwave. And I think because the broad insertions of a plantar fascia and Achilles tendon, for me, I think the radial, I'm interested. I think if you're treating bony pathology, that's where focused has a greater evidence based. If you're treating things like stress fractures, bone marrow edema, those type of things, the focused may be better tolerated in those cases. But I think when it comes down to the most common things that make up 99% of what I see, the evidence is really, I think, there for radial. And when it come to, and I did get to a point maybe last year where I was really interested in focused, and I think I just couldn't quite justify it from a business point of view because there just wasn't enough bony pathology that I was seeing. If you were doing a lot of sort of treating arthritis and things like that, knee arthritis, that's where maybe focused sits in, or you're treating non-union fractures, that sort of thing. But rather than purchasing a focus machine, I ended up just upgrading and getting a power handle in there as well. So I had that greater range. So, even with the power handle, there is different attachments. So there is even one that is a little bit more focused if you're trying to hit a more narrow point. So yeah, I use the radial primarily, pretty much.
Fantastic. Marcus, you like the power handle as well. I was listening in earlier.
Yeah, I've got both. I've actually got one of the, I think it's the middle range one, and I've also got the brand new Shockwave as well. So I'm using both. The new one doesn't have a power handle yet. That's coming out, I believe, soon. But yeah, it gives us a lot more range, the power handle, to access bigger joints like hips and just the bigger muscles if you're going for the glute or lower back. It's a bit more effective than just using the Evo handle. Terrific.
And Adam, did you do any research in regards to between focused and radial and other shock waves, and why did you come to the decision to purchase this one?
Yeah, so the literature actually shows there's no advantage to the focus when treating your standard like tendinopathies and stuff like that. And in effect, with the focus, because it comes in into a smaller area, it's actually more difficult to target the tissues, whereas the radial comes out in a conical spread, so it's a lot, the sweet spot's much larger, so it's a lot easier to get the target tissue. There's more allowance for error there, whereas the focus, you have to be spot on. So a lot of the practitioners who use it actually use they're using ultrasound to actually make sure they're in the right spot. And the literature, again, when there's no advantages in terms of effectiveness with the focus versus the radial.
Right. Marcus, just here, how do you there was one question here that was very good, and I'm just trying to find it.
Marcus and Adam, do you use Shockwave much on lower back and things like that?
I use it a little bit on lower backs. It's probably the area I don't use it a lot in.
Yeah.
Yeah, Adam, I don't know if you use it more in the lower backs.
Yeah, I actually don't tend to use it a lot on low backs. I probably should a little bit more. But the people I have used it on, it is quite effective at loosening up those, the tight erector spinae and getting into like the QLs and stuff like that. So you do get a very good effect working. You can get rid of those trigger points, and that makes a big difference for the tone of those muscles. And if those muscles are really tight, they're actually compressing the spine. So I think people tend to forget about that, is that those myofascial slings, when they're really full of knots, they actually have more tone, and they're causing compression of the spine. And if you can release some of those trigger points, then obviously you're decreasing the tone, which is decreasing the compression of the spine, which is obviously going to have significant effects on their symptoms and mobility as well as pain levels.
Actually, I'm just tying onto this chap from Ben Day who said it has an amazing research on facet pathology. I'm presuming that's on the lumbar spine. And I can actually say that that's something I will use it on sometimes, is lumbar facets, because you can actually put them in varying ranges. So if they're struggling in extension or they're struggling to get into flexion, I'll actually get them in the positions that they struggle in, and I can use a shockwave on them. And that ties into a little bit of an advantage over something like dry needling, where you've got to keep them fairly stationary. With a shockwave, you can take them through movement. So that's a great advantage, I think, with having the shockwave there, is you can load them up. And in this case, I'm sure that, I haven't seen that paper that Thomas Needle has talked about, but he might have taken the joint through range or found where the facet's restricted and actually put them there and then treated them in that position.
Yeah, I agree.
Yeah,
I like
makes
even
sense.
just with
That'd be a smart move.
Not that I've got any
Go ahead,
experience treating backs, but I think when I'm treating even things like Achilles and plantar fascia, I always like to treat them with some tension on the tissue. And I think it's also really important just for patient comfort to actually really sort of quite firmly, particularly extremities like the foot, the ankle, actually to really stabilize that limb. I think it just makes the patient feel more comfortable, but also it gives you the ability to put a little bit of tension on it as well. And it tends to dampen sometimes the reverberation that they might feel in their ankle can actually be what's more uncomfortable than the area that you're treating. So yeah, I agree. I think it giving you that ability to actually, even with an Achilles tendinopathy, to actually work it through various ranges of motion as well, because you're looking at effectively sometimes issues with planes of tissue moving properly. And when you can treat in that more dynamic way compared to more stationary, I think it has a huge advantage.
I totally agree. When I treat shoulders or Achilles, I'm always putting tension. Like if I'm doing an Achilles, I'm always putting the patient into dorsiflexion, and when I'm treating it, I maintain like a steady pressure, and you can actually feel when the tissue releases, you'll feel that ankle just release, and that usually patients can feel it too. They go, "Oh wow." Because you'll have, a good maybe 2 to 5 degrees increased dorsiflexion when you release those tissues, and all of a sudden that change in range of motion that the patient can really feel, and that's going to help them walk way better in terms of biomechanics and all that. Yeah.
Marcus, there's a question here about the use of EMS shockwave on osteoarthritis. You've got some experience in using it on OA?
Yeah, I do use it on OA. I use it as a massive adjunct to exercise. I want to be really clear that exercise is by far and away the most evidence-based modality. But I've found that, let's take a knee, for example, if I use shockwave as that adjunct in that therapy session, they're often able to do more exercise. So that's one of the big reasons I'll go for it. But it also gives me that opportunity to, if I've given them some rehab, I'll then say, right, okay, you go and do that rehab for a week or 2 weeks, and we'll see how you go on that initial stage, and then we'll have a chance then to reshock it. So it ties in with how I want to connect with them in terms of progressing their rehab. So, and it gives them that stimulus again, something's actually happening. And I've used it. I've tried using it independently with patients, and this is, I guess, something the research backs up, that if it, as used as an adjunct with exercise, it is a very useful tool, and I found that in practice. And actually, I find they are more, they tend to follow up better as well. They're more likely to come to their following sessions, so they also know they're going to get some pretty full-on treatment. that reduces pain. So I found better. They were better adhesion to the actual routine of coming into physio and getting their treatment, plus getting you exercise. So.
I completely agree. Like sometimes as a podiatrist, we'll just, from our uni days and so forth, you'd might say fit someone with a pair of orthotics. You say, look, if you have any problems, come back and see me in 2 weeks. Otherwise, I'll see you in a month or 6 weeks later. What sometimes happens is when you do Shockwave and you see that patient each week, you're often able to work out, you can check in with them, and sometimes patient will come back and say, oh, God, I had a really bad week this week. And then you say, oh, look, well, what have we done different this week? And you can actually sort of problem solve a little bit, and you find out, look, they're doing a home renovation. They've got, Achilles tendinopathy, and they've spent the weekend up and down a ladder. And sometimes patients don't put those things together, but when you see them, in that sort of each week, you're able to adjust their exercises. So I'm often, you might need to make a little adjustment because they're not tolerating an exercise properly, or you give them advice in terms of managing their load. It really does help with building that relationship. And really making sure that you're really working with the patient, as opposed to here's an intervention, let's see how you go in a month's time, or here's some exercises, I'll see you in 3 weeks' time. They may not be doing very well during that period of time.
Absolutely. Adam, here, what is majority of patients' outcomes for, say, Achilles tendinopathy, moderate damage after first session?
Sorry, repeat the question.
What's the patient's outcomes for, say, Achilles tendinopathy? Is there any moderate, and they've got moderate damage after first session? And how many shocks per treatment?
Yeah, so with that, again, you're kind of looking at the around 2,000 shocks per area. So if say it's a mid portion Achilles tendinopathy, I generally always work the insertion anyway. So I'll work the insertion. I might do 2,000 shocks there, and then I'll work the mid portion, which is usually maybe 3 to 6 centimeters higher. But that's just the way I do it, and then I'll work the medial aspect. I see Marcus, did you want to say something?
Sorry, carry on.
Oh, okay. So so I'll work that, and then I'll even do some like trigger points up through the gastrocs and soleus in there as well. So I'm really just feeling for where if you're new to it, you're kind of just you can always ask the patient where they feel it. So after years of using it, I just kind of know, and I'll like kind of ask them while I'm telling them. I'll be like, right here sucks, doesn't it? And they go, oh yeah, you're right on it. But when you're new to it, just ask them. Just say, tell me where you feel the most pain. And when you find that area, you just kind of work that area until you decrease the pain. So I usually tell them, tell me when the pain starts to alleviate, or sometimes a better way of wording it is, tell me when it starts to suck less. Right? or you're starting to get used to the pain. Sometimes it's just in the wording, because I used to say, does that feel better? And they go, no, it still hurts. But they went from like a 7 out of 10 to like a 3. And then I would be like, does that suck less than it did at the start? And they go, oh yeah. Which in other words is saying better, right? But if you say better, they'll always respond with, no, it still hurts, because you haven't taken them down to 0, right?
Marcus, there's a question here. We obviously use Shockwave for plantar fasciitis, but the cause of these conditions is often tight calves. Do you use Shockwave therapy to release tight muscles groups as well?
I sometimes do. I'll also use dry needling. This is where it might tie hand in hand. That might be a question for you, Adam. You're going to be talking about trigger points. Did you want to take that one?
Yeah. I actually just looked up a study today, and it was talking about one group. They did just Shockwave on the plantar fascia, and the other group they did Shockwave on the plantar fascia and the gastrocs, like the trigger points, and the group that had the trigger points on the gastrocs plus the plantar fascia had superior results compared to just the Shockwave on the plantar fascia alone, which makes sense because usually when you have someone with plantar fasciopathy, it's the whole myofascial sling going up, the posterior superficial back line, according to Tom Myers. So most of them have tight calves or restricted dorsiflexion. So if you can increase that, that's going to have biomechanical and pain relieving effects on their tissues.
There's a question here, and I'll leave it up to you decide who would be best to answer this. Do you do soft tissue before or after shocking, say, on the calf?
Marcus, you can take this one.
Oh, you're muted, Marcus. Sorry.
I'm just coming up. Sorry. It actually depends. If they're really thick and tight, and my hands are really going to get copper beating, I'll start with a Shockwave. If it's gone smoothly and the calf moving well, and there's just a couple of little points left over again, I'll mark on the spots where those are, and then I'll Shockwave it afterwards. So it's kind of not a hard and fast rule with the way I use it. At least I'll just depend on the person and also what they can tolerate. Because some people, they just can't take the Shockwave straight away. They are that tight, and you'll try to think of starting it, and they'll resist. So then I'll go for hands first. I'll get into them manually a bit first, or I'll kneel them first sometimes, then I'll come up with the Shockwave and clean up whatever's left over.
That's fantastic. I really like this question. Are there any good tips for links to research? Would be greatly appreciated. I suppose that's a key point of difference for EMS, is that we have so much research backing us. Adam, was research a big factor for you when you were thinking about what Shockwave device to purchase?
Well, I was kind of biased because the practitioner I was working for, he had one, and it worked really well. So I was kind of biased to start with. So I'll admit that straight off the bat. But yeah, it does influence you when you see that. What I say at the seminars is that a lot of other brands actually use our research to validate. They'll say Shockwave does this, and they're actually using our research. So it's not Shockwave, it's actually EMS Doloclast does this. It'd be like saying cars do this when it's research about a Ferrari F350. Well, guess what? A Toyota Camry same as a Ferrari F350. So they're not the same thing, and that's what I try to explain to people. So sometimes I'll have practitioners ask me, "Oh, I've seen this Shockwave device. It's only $5,000." And I go, "Well, you always get what you pay for. The reason the EMS devices cost more is because we put quality products, we put quality components that are tried and tested and safe and effective, and we guarantee that. So when you buy these other devices, you don't have those type of guarantees."
Absolutely, that's true. And there's a question here: where can we find relevant papers and research for different pathologies? Where do you do your research?
So
Pedro?
the best one's Pedro. If you go on to Pedro, it's free. You can access full text research, which is great. Sometimes I just go on Google Scholar as well. Yeah. What do you guys use, Marcus and James?
I use Pedro.
Yeah, Pedro, sometimes Google Scholar. If you can see the method, they'll often tell you what machine they used. But even the EMS portal, if you go into the different indications, you'll actually see the studies that are specifically. So if you go into the EMS portal, you go to heel pain, you'll actually see the studies where EMS units have been used on heel pain. And I completely agree with what Adam said. I've locumed in a practice that had a different Shockwave machine. I'd always, when it comes to making a purchase for my own clinic, it was pretty much I'd used Shockwave already for 5 years at this point, and I used the EMS one and it worked. So for me, it was a risk of buying anything that was not that. And having used different machines in different practices, it might go up to 5 bar, but that's the pressure inside a small compressor. That's not the pressure that it's delivering to the patient. There's a whole lot of other steps that are involved in actually getting that energy into the patient. And I know in using some different machines, like 3 bar on the EMS, I could be using 4 bar on a different machine, and you can put them sort of side by side and you can feel there's a significant difference. Even the handpiece had a lot of plastic components on it. You're going to lose energy in plastic. So yeah.
And all the Pedro studies on radio have been done on EMS devices. So we'll place a link. We'll send an email out to everyone afterwards, just with some links to some good research, so everyone can take a good look at that. Now, do any of you use Shockwave for regenerative therapy, e.g. trying to stimulate cellular proliferation? I'm sorry, I don't have my proper glasses on tonight, in damaged cartilage? I hope I pronounced that okay, that you can understand.
Look, I don't think there's really very good evidence in a lot of things. Even people have a misunderstanding of how stem cells work and things like that. When it comes to, for example, there's really no good research in terms of cartilage regeneration. The closest thing that's got was a procedure where a piece of cartilage was a tissue sample was taken, and then it was cultured, and then it was basically surgically implanted back into a deficit where there might be an osteochondral injury. And even that procedure has a large fail rate. It's very hard to make that work. Now, even with things like stem cells, when you're injecting stem cells into a joint, and people have looked at this and they've used radio sort of active markers on those cells to see what happened to them. And basically they die over the course of a month. And one of the sports radiologists I did spent some time with when I was doing a lot of the tissue regeneration, a lot of the PRP and orthokine and those sort of injection-based therapies. He actually invested over $100,000 in a stem cell lab. And I remember him saying because I asked him, look, from a clinical point of view, do you see much difference between PRP, for example, or orthokine versus stem cell? Because the cost is hugely different. You're looking at sort of $8,000 plus there's a lot of additional risk because patient needs to be admitted to hospital. They have to undergo a liposuction procedure to get the fat that has to be processed. So there's a lot of extra additional fees that go into that, and also risks to the patient. He said, look, none. There was not a significant difference he noticed. He said, what I think was happening was you're injecting those cells are dying. It's causing some sort of inflammatory reaction, pretty similar to PRP. And the patients sometimes have a decent response to that for some people. I don't think there's any really good evidence that, shockwave injection stem cells are regenerating cartilage. The best understanding of those sort of treatments at the moment is that they influence the micro sort of endocrine environment, sort of signaling between cells. But I don't think the evidence is super strong, and they're quite expensive procedures and things like that. Shockwave, we don't fully understand the full. We don't fully understand the mechanism, like a lot of treatments that we do. Even things like, we don't fully understand all the pathways that are involved in even things like cortisone, for example. We understand some of the more well-known pathways, but we don't fully understand a lot of things. Shockwave's a little bit the same, where there is different hypotheses and things like that. And a bit like Marcus said earlier, it's interesting, and I'm interested academically about those things, but I think from a clinical point of view, I don't tell patients that it's regenerating their cartilage. When it comes down to treating people with, say, osteoarthritis, it certainly can have an impact on their pain level, And if we're able to reduce their pain and get them better able to walk comfortably, to exercise and to do that, that's going to really provide them the benefit. I don't tell them Shockwave is going to cure their arthritis or anything like that. It's a tool that may help improve their pain for a period of time.
There's a question here. Can someone please explain the physiology of shockwave therapy? Who would like to take that big one there? Adam? Marcus is shaking.
I was seeing if you guys would put your hands up. Okay, yeah, so the physiology of it is, so shockwaves are acoustically generated waves that there's two components to it. There's a positive compression phase, and then which is followed by a negative tensile phase, which is below ambient pressure. So that causes a somewhat of like an implosion change inside the interstitial fluids, and that leads, when you to calculate the energy flux density, which is another way of saying bar pressure, you add the area under the curve of the positive compression phase minus the area under the curve of the negative tensile phase, and that gives you your energy. And so the most studies have shown that it's really about the energy, the amount of energy you put into the tissues that causes physiological changes. And so those, again, going back to those two phases, the tensile phases causes the formation of these what we call cavitation bubbles. And these cavitation bubbles, when tissues are bombarded with these cavitation bubbles, it causes physiological changes within those tissues. So we get several physiological changes that occur. One of the big ones we like to talk about is we get a decrease in substance P. So the nociceptors are the nerve pain receptors, have substance P in them, and they only have a limited amount. So it's similar to, like, we talk about the red hot chili pepper effect. When you put a chili in your mouth, when you first start tasting it, it burns and kind of hurts, and then after a while, it actually your mouth and tongue kind of go numb. So that chili's actually it's decreasing the substance P within the nociceptors in your mouth. So that's why you get an analgesic effect. So that's one of the big effects we have. And what Marcus was talking about is one of the therapeutic effects we can gain from that is, if you can decrease someone's pain in an area, then you can load it or train it, right? If someone's shoulder's hurting so much that they can only get to maybe 90 degrees abduction. Well, after a treatment, if they can get up to like 120 degrees abduction, well, then we can train them in a range that they weren't able to before, and therefore stimulate greater physiological changes within those tissues, because we can get them into ranges of motions or areas that load the tissue in different manners. Some of the other ones are, we get a proliferation of stem cells. We get angiogenesis. We get release of lubricin from tendons, which helps with the lubrication of the tendons. We also get proliferation of fibroblasts and osteoblasts and tenocytes. So we get, what I tell people is, basically we're stimulating the tissues to cause all these repairmen to come to the area. It's like I'm ringing the fire alarm, and the firemen come, and the ambulance come, and the police come, and they deal with the emergency. However, if I don't ring that bell, none of those repairmen come to that area. Your brain and your body just go, oh, that's fine, we've dealt with that. But what we're doing with the shockwave is we're similar to what Marcus was alluding to before, is we're telling the body, hey, come here, clean up this mess. There's still problems here. I want you to come clean this up. And so that's the best I can do for that.
No, brilliant response there. Brilliant. I'm going to tape that, and I'm probably going to put that on our Facebook page. Thank you. I've got Andrew here is about to introduce Shockwave, so I'm hoping that that's EMS Delta class. I'm considering, would love your help on hip impingement, labral tears, bursitis, hip capsule adhesions. So yeah, just some general comments he's looking for and how to treat those. Who would like to take that question?
Marcus, you can have a go, mate, if you want.
Yeah, I'm just getting so I use it quite.
Labral tears.
Looks like there's quite a bit on the hip there. I do use it quite a bit around the hip, I have to say. I get a lot of use for it with posterior hip capsule adhesions, trigger points through the piriformis. I use it quite a bit. I'll use it very carefully around the greater trochanter and the femur, so careful not to hit the bone, but it can be very useful for bursitic conditions. And I come quite anterior as well on that, so I'll try to hit the ITB origin, and I use that quite a bit for those sorts of conditions. I don't use it a lot for labral tears. I have what else have we got here? Hip impingement. Bursitis is part of that. Not really for impingement, but if it helps them release certain parts of the posterior capsule, which then allow them better motor control within the hip, then you'll get a secondary effect on the hip impingement thing there. But rotator cuff conditions, I use it. Yes, I do in a limited way. In the same way that Adam was talking about getting more range, I might help them into a bit more range, or I'll use it while they're in those ranges. So if they're restricted through some form of rotation or some form of end of range, I will take them into that end of range. So if they're lacking that last little bit of flexion or even abduction, I will go through that. And one of the things I'll often do all my standard treatment, my standard exercise, and then I'll take them to the part that I just can't get them to, and I'll ask them to point where the pain is. And they might be going hand behind back and they're still getting that anterior pain, and I'll hit them on with a shockwave on that while they're doing the hand behind the back. Or I might even do some mulligans with the belt while they're doing that, and I've got the shockwave on that anterior capsule, and that can work very, very well. Ligament adhesions, that was it, the one. Hamstring, chronic tears. I tend not to use it on chronic tears. I go just for rehab on those and soft tissue and dry needling, but it's not to say that it can't be used. There's obviously going to be some evidence there for work in the muscle. I think we'll answer some more of those as we go later on too, but that's, yeah.
Thanks, Marcus. There's also a question here, Marcus, about if shockwave is contraindicated for those with metal plating or post-ORIF.
Yeah, I won't use it around, am I muted?
No, yeah, or click the mute button again.
Sorry. Yeah, I don't use it around metal. I won't go using it around an RF. I won't go using it around a hip replacement. I don't know if you do, Adam, but I don't tend to venture around joint replacements.
Yeah, I used to work for an orthopedic surgeon, and so I had a fair bit of experience working around patients with hip replacements, knee replacements predominantly. And you as long as it's not directed right at the implant itself, it's usually pretty safe. So it really depends on how you direct the handle. So you try not to get right on the implant. There are some studies I've seen where they say there's a potential where it could loosen the device and whatnot, but in my experience, it actually had really good effects, because if you can, especially for the scar, if they have like a hip replacement, you can break up, if they do posterior approach, and you can break up all the adhesions and the scar tissue and the glutes there, it makes a huge difference for how well they move. And it also helps with the healing of the scar itself. Like I got some, even patients that have had surgery years before, I was able to really soften their scar or break up adhesions in the deeper part of their scar using the shockwave.
Fantastic. And Ben Day's actually put a good research there in the chat with Dr. Matt Becker, who's shown that EMS radial shockwave in a 12-person study showed resolution of tendinitis at 12 months post. So we will share that case study as well. Just a question here, James. How soon after an injury, can you use Shockwave? Say they've strained their Achilles at a Saturday tennis match, for example. That'd be nice to pay some community sport at the moment.
So in general, I think I'm sort of lucky because I've got access to ultrasound in the practice as well. So I'm primarily treating it when we've got degenerative, like a degenerative Achilles tendinopathy, for example. I think what it comes down to, I don't necessarily, I'm not really treating acute injuries. You can, with acute injuries, what I will treat sometimes is myofascially. If the patient's in quite a lot of pain, I'll treat the myofascial pathways to get them effectively mobilizing a little bit better. But generally, if they've had an acute injury to an Achilles tendon, I'm not really like a reactive tendinitis. I'm not treating that. But having ultrasound, I can really see whether there's degenerative changes in the tendon or not, and that can be really useful. What I think in terms of the timing of Shockwave, I'm to a degree going off the patient. So sometimes you see these patients in an acute on chronic presentation where they may have had, for example, heel pain for the past 6 months and they're otherwise coping pretty well. And then they'll come in with this acute on chronic exacerbation, and all of a sudden the pain has shifted. It's become a little less stable. They've maybe got a little bit of nocturnal pain. And in a lot of those cases, when I scan them, you notice they've got a small intrasubstance tear or there's been more significant delamination of the tissue. For those people, what I'm doing is I'm getting them out of that sort of flare of pain and getting the pain. Effectively, I try to get their sort of on a visual analog scale, try and bring them, if they're in an 8 out of 10, I try to get them closer to that 5 mark using all those other modalities, whether it's dry needling, whether it's bracing, whether it's compression, orthotics, some gentle rehab or isometrics. And then once I've got their pain stable, that's when I'll implement Shockwave. If you have a patient who's in that acute flare, and they could have had the pain for 8 months, and then all of a sudden the last 3 weeks it's really flared up. If you Shockwave those patients at that point, my experience is they don't tend to tolerate it very well, and the results are not often that good. It's a little bit around the timing. So what I'll often do is I'll say for that patient, you're not ready for Shockwave yet. We're going to work with all these other modalities that we've got. We get them out of that acute flare, and that's when we bring Shockwave. They tolerate it much better and they get a much better result from it. So it's not necessarily a hard, fast timing of, okay, if the patient's had pain for more than 6 weeks, I'll Shockwave them. It really is an individual approach to the patient. And I think using that approach, I've been able to get much better results, because I think early on, I probably Shockwave patients that were too early, not necessarily because they'd had the patients that I didn't do very well with in my first, few years of using Shockwave were those patients that, come in with an acute on chronic presentation. They might have had the pain for 9 months, but they had this flare up in pain. You can use it in that circumstance to treat myofascially, but the treatment itself is often not, I tend to hold off a little bit till I get that pain stable.
Marcus, how early do you normally do Shockwave post-surgical repair? Let's just say of an Achilles tendon rupture.
I don't.
I'll just jump in here. That's a contraindication.
Yeah.
So we
Perfect.
don't.
Thank you. We don't, Mark. We don't. Yeah.
So that's an absolute contraindication.
Yeah. Perfect.
So don't.
Yeah. Don't. Yeah. Mark, no.
Yeah.
Now, there is a question here. Do you Shockwave work for a sportsman's hernia?
I'm not aware of any research on hernias. You guys?
No, I'm not aware of any.
Me neither.
So that's a sportsman's hernia. Is that an inguinal hernia? Is it?
Yeah. There is a question, is there a list somewhere of all the contraindications? Yes, there is, and we will send that in our post email after the webinar. We'll send a link to all those listed. There is a question here. I know we touched on this at the beginning, but thoughts on focused versus radial Shockwave. do you have any advantages over each other in different applications? So I think we covered off what the difference was, but maybe not the different applications.
So really the main difference is simply the depth of penetration. That's the big difference with the focus. It's also piezoelectric, so it hardly makes any sound. So some people complain about the sound when you're using the Doloclast and other radio shockwave devices. The focus makes like a clicking sound. It's like click 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 click, and that's really it. But you get 8 centimeters of depth with the focus. So you can get to those areas either on really large, either morbidly obese patients or really muscular, like big rugby players. You can get down to the really deep tissues that you wouldn't be able to get with the other devices. Or again, it's the problem is, though, you have to be very precise, and the applicator, it has different heads on it, so you have to get the size of the head correct as well to get the proper depth. Because if the patient's tissue where the problem is 6 centimeters deep, and you have the 8 centimeter applicator on, well, you're overshooting it. You're kind of missing the area. So you have to be more precise with the focus. Whereas the radial, it's very forgiving. So if I treat something that the problem's at, say, 3 centimeters of depth, it doesn't matter if it's at 3 or 2 or 4, I'm still going to get it. Does that make sense? So it's a little bit more forgiving in those terms.
Marcus, you have the same thoughts on that?
I haven't used the I've only used.
There's a couple of questions here about the indications for shockwave, because obviously we've covered off a little bit about the contraindications. James, you've had some success with the radio shockwave with wound care. Do you want to go into a little bit more detail regarding that?
Look, it's not something I've done for a while, but when I was working rurally, I did have quite a number of patients with chronic wounds. And again, it's a similar type approach to musculoskeletal. When the standard the standard approach often where these are vascular sort of diabetic wounds sometimes, or when that standard approach is not necessarily, it plateaus occasionally. So their standard wound care, debridement, dressing. So there's one particular, actually, see if I think I've actually got I've got a few slides of a patient. This was treated quite a while back. I might see if I can share my screen.
Just the little green button at the bottom there. Perfect.
There we go. So if I maybe see if I can current slide. So this was a patient, this is quite a while back, it was 75-year-old COPD, hypertension, hyperkalemia. He was actually in hospital for, I think, a knee replacement. He developed a posterior pressure wound on the back of his heel. And this was, when I saw him, he was referred by the wound care consultant at the hospital after, I think, 8 months of treatment. He had strong sort of pedal pulses. His feet were cool to the touch. Doppler showed reasonable arterial flow. His sensation was he had some degree of neuropathy. Looking after, I would say after a few months of standard debridement, I did utilize Shockwave. And the approach I took was effective sort of debridement. He was, we were managing the fluid of the wound. He was getting redressing with district nursing, and it was also offloaded as well. So like with Shockwave with musculoskeletal conditions, you have to address the underlying causative things first. If you jump to Shockwave before you've addressed their load management, their rehab, all those other sort of factors, that's when you're less likely to get a great outcome. So this is how I'd prepare the wound beforehand with some debridement. And in terms of the treatment itself, I'd use either a bit of, saline, the wound's moist itself. You use some cling film over the top of the wound as well. and then you apply the gel on top of the cling film, and you can use your Shockwave machine there. So in this case, I think I was using the 15 millimeter sort of handpiece on the Evo, and you're treating it around, I was treating between sort of 2 to 3 bars. This patient had some degree of neuropathy, so treatment was very sort of well tolerated. And towards his last treatment, we really did get some significant sort of healing. So I was using 3 bar on him, 10 hertz, and that really did, within a short period of time, we went from being really quite a plateau in his recovery to quite quickly improving the state of that wound. So that's sort of a non-standard. And there was other patients that I treated in a similar way. It wasn't my sort of standard go-to, but occasionally for patients, I would hit a little bit of and in his case, the aim was to promote some angiogenesis. I knew that he had good flow through the big arteries, but there was clearly some degree of compromise to the microvascular flow, because this was a patient who wasn't diabetic. There was no degree of peripheral vascular disease there, but still he wasn't responding that well to standard wound care. So Shockwave was helpful in that case.
There's a question here from Brianna. How did you ensure good infection control when using it on a wound?
So the handpiece, the applicator tip, as I said, you're using a barrier on the wound. So the Shockwave, the handpiece itself is not making contact with the wound. You're using a barrier, and that barrier could be some cling film. It could be a tegaderm. And the handpiece itself, just for enhanced infection control, I would sterilize that before and after treatment as well, because the EMS applicator tip can be, as you know, you can unscrew it, take the O-rings off, and you can put that through your autoclave. So in that case, I know that I'm not contaminating his wound, but also I'm not, even if there's any break in that, in the barrier that I've used there, we're able to sterilize that. And there is some, if you do jump onto the EMS sort of portal, there is some studies of Shockwave that's been done with the for wound care for the EMS one. So as I said, in Melbourne, I really don't do any wound care here, very, very rarely. But where I was working more rural, we didn't have those services. So I used to receive a lot of referrals from GPs, from local hospital for wound care. And for a small selection of patients where we, after a good period of time of that standard care, we weren't getting a response. Occasionally for the select patient, I would discuss using Shockwave. And I had good results.
Oh, perfect. Thank you, James. And again, we'll share the links to the research as well. There's a question here, is training available in use of the device? Yes, it is. And all of our wonderful experts here actually do small group online training. So if you have some specific questions and want that addressed, we'll send a link as well in the email where you can sign up to those small group online training and be able to have your more specific questions answered. And that is free as well. Marcus, there's a question here in regards to, Adam, here, just in regards to when you say release tissues, just this anonymous attendee would like a little bit more information in regards to that.
So when you're treating tissues, soft tissues, such like when I use ART, I can actually feel a change in the tone. So you'll feel a change in the patient's range of motion. There'll be less resistance in it. So that's what you can feel. So I tell people, when you get experience with using the Shockwave, it's almost like the handle's an extension of my arm or my hand, and I can feel. And I have one patient. He always laughs because he can feel it as soon as I say it. I'll say, "There it goes." And he says, you get it bang on every time, because he can feel it release as well. So it's more of the tone changes. There's a change in the range of motion. So that's what they feel. As to the mechanism of action, where no one's precisely sure what occurs, but it's reproducible and it's effective. So you can get the same result over and over with doing the same therapy.
And Ben said here that feel is quite unique to the EMS dollar class. You don't get that with any other brand. So thanks.
Yeah,
for that
comment, partially that's due to our spring-loaded head on the handle. So some of the other handles on other devices, they don't have that spring-loaded head. So when you push in, you're not getting as much feedback because there's different pressures you can push in with. So it allows you to kind of feel through the tissues. To see how compressible the tissues are. Again, it's giving you a feel of the tone of the tissues, whereas the other devices that don't have that, it's kind of like it's digging in, like a blunt instrument kind of digging into you, almost, when you have like a spiky ball digging into you, it's like, oh, kind of thing, slightly unpleasant.
There's a follow-up question here. Does it break down scar tissue?
Well, again, that's it. We haven't. I don't think we've been able to show like scar tissue per se. Again, it causes changes within the tissue. So whether you describe breaking down of scar tissue is due to increased proliferation of fibroblasts, tenocytes, osteoblasts, increase in angiogenesis, new formation of blood cells, increase of collagen, increase of lubricin. Well, if you deem that those things cause so-called scar tissue degradation, well, then there you have it. So we can call it by something else, but it causes, again, these are the changes we've been able to measure in clinical evidence that occur. We've been able to measure that there's an increase in all these types of cells. So again, the way I explain it to patients, if I get more repairmen at the site of the injury, we're going to get a better job. It's just like if you had more repairmen come do a renovation on your house, it's going to happen quicker and probably a little more effective than if you had one or two repairmen working on your entire house. Does that make sense?
Another good patient analogy. I'm going to add that to my list from tonight there. Marcus, how do you set patient expectations on the response to and the duration of treatment needed?
I actually say to them from the first session, we will see how this goes. This may work very well for you, and for some people it might not work well. So I set quite a neutral tone on that sense, and I see how they go. I typically can tell how they're going to respond between the sessions based on how they've gone during that first session. If they're able to, if the spots are, let's say, getting less painful as I'm on them. And I'll usually say to them, look, we'll see how you are. And that first session, I follow up very quickly, like within that first 7 days, not closer than 5 days, but up to the 7th day. And the first session is usually done, as Adam said already, a bit lighter. We're not going too hard on them. And in general, then you won't get that the potential negative reaction where it's a bit too sore. They can get sore for a bit too long after it. And I'll let them know that once we've seen how they respond in the first session or two, I'll have a pretty good idea of how many sessions it's going to take. And that's just experience and a bit of trial and error. And if they get 20% improvement and you've done a session, that they might take the 5 or 6 that James was talking about. And you might have some that are a bit more of a long draw where you'll do 2 or 3 and then you'll space them out 2 to 4 weekly. So I think the setting the expectations is initially about making sure they understand what it's going to feel like, and then letting them know that it'll be an organic finding of what it's going to take in terms of how many sessions. But in general, I tend to go with James and say you're looking at that up to maximum 6 amount as a rule of thumb. But again, that can depend really on the patient and then how I'm using it and integrating it with exercise along the way. So I might have them under my care for a few months, but I might only see them once every month or sometimes longer. So the Shockwave will still be used at those times. But setting up at the beginning, it really is just setting it up, saying, we'll see how this goes. This should have the effect and desired outcome, and we'll go each session at a time.
Oh, great answer. It's dependent on the individual, isn't it? I'll ask this of you as well, Marcus. How do you think Shockwave compares to steroid injection and light in stimulation of repair? Sorry.
Yeah, look, I think they're totally different in the sense that it depends on the area. So take, for example, a shoulder. Before someone jumps off to do any sort of cortisone injection, I'm going to try a course of conservative management, which would include exercise rehab and possibly the shockwave. And I would keep the option of the cortisone in the background to come in later on if I need to, if I hit a snag. If someone comes in with a very acute bursitis off a trauma, I'm going to go straight for the cortisone. I'm not going to fiddle around with other things in that early stage. I'm going to try to get that very quick involvement early of the maximum amount of pain relief. So I think that is a question that is difficult to answer because it's so different for different stages. I tend to say, in terms of hip bursitis, I almost routinely don't recommend any cortisones anymore because I think the use of the shockwave is very, very effective, and if not more effective. But they do different things, and I'll call upon them at different times for different reasons. So that is kind of a loaded question in that sense.
We're running out of time here, so I might take one final question. But before we finish
I just wanted to add a little bit to that as well. With the cortisone, there's the potential for side effects, right? So it's an invasive procedure, so you always have the risk of infection with it, and also you also increase the risk of causing spontaneous ruptures of the tissues because the cortisone itself will erode the enthesis. So for plantar fasciopathy, for instance, they showed that when people had 3 cortisone injections within a year, it increased their risk of complete rupture by tenfold. So 10 times greater chance of having a rupture of your plantar fascia if you've had 3 cortisone injections within a year. So that's it. And also you run the risk of you can hit nerves and stuff and cause problems if you inject into nerves. So I did a presentation on this a few months back. We did a webinar. So if you want to put links up to that, I discuss it thoroughly in that.
Absolutely. No, that's a good point. We'll certainly put those links up. James, if we were to take away your shockwave, could you work without it now?
Look, I've worked with it for 10 years now, so no, probably not. Because I think when it comes down to a lot of those, it's just taking away a tool. I think like Adam was describing earlier, it's just a tool. And, we try different tools on, I think, as clinicians, particularly when we're new and we've just graduated. We try lots of different things, and the things that work tend to stay with us. And there are things that, we just don't get the results that we wanted it originally, and we tend to move a little bit away from those. And Shockwave's something that I use more now than I did at the start of my career. So, no, I think I'm quite happy to keep it in there.
Certainly. Last question, Adam. I'll give this one to you. There was a question at the beginning that the person wanted an elevator pitch as to how they describe it to a patient, which Marcus did it incredibly well with that one. They also asked for an elevator pitch on how they would then sell it to another practitioner. How would you sell it to a practitioner? What would be your elevator pitch?
Oh, okay. All right. Well, again, it's one of those things. It's the clinical evidence speaks for itself. So there's no other electrophysiological device that I'm aware of that has the clinical backing that this device has. Like, for instance, if you look at the studies for like Achilles tendinopathy and plantar fasciopathy, it's usually around 80 to 85% effectiveness, and those numbers are crazy. Like, if you got those kind of numbers from a pharmaceutical drug, that like every single doctor in the country would be pushing it. So and the other beautiful thing about it is I talk about this in my presentation, this meta-analysis that included I think it was 6 RCTs, had 1,200 patients there was, and out of those 1,200 patients in the treatment groups, there was 0 side effects, or sorry, 0 adverse effects. So that there might be small little side effects where there's some discomfort or some petechia or a little bit of swelling afterwards, but adverse are kind of like major problems involved with it. So it doesn't get any safer than that. 0 out of 1,200 people is amazing. Like if you had a drug that had 0 adverse effects, again, the medical community would go bonkers with that. They would be on front page news. So it's one of those things that it's effective. You will see the results, and you can see the results within one treatment. You get that analgesic effect. You get that the decrease in substance P straight away, and the patient can feel the difference. And again, they might not notice, but that's where you have to verbalize it to them, where you go, what's your pain level at the start? So you get a baseline, and then after you've held it in the same spot for a while, you ask them what their pain level is now, and they tell you the answers. So you can't really fake that. You can't. It's an objective. Well, it's subjective for them, but I'm not putting words in their mouth. I'm not making them tell me those numbers. They're telling them by their own free will. So it speaks for itself. It's, again, safe, it's effective, and and you can, as James alluded to, you can make it quite financially viable in terms of generating another stream of revenue for you as well. So there's another bonus for it.
I think what I've found the best way for practitioners is in terms of gaining referrals from different practitioners. It's asking your patient whether you can, write a correspondence letter to their GP. You've just treated them. That's probably one of the most effective ways, because you can actually say, I'll ask patients, look, do you want me to keep your GP informed? And they'll often say, oh, that'd be really great. And, you can write a correspondence letter to the GP with some of their functional limitations, their pain pre-treatment. You can explain that, look, we undertook a series of 3 or 4 sessions, and then you talk about their results 6 weeks later. And that sort of stuff is, when it's their own patients, that's what really touches home. I think they're obviously, talking to a GP, there's drug reps coming all the time trying to get them to prescribe new drugs and things like that. They really do care about their own patients, and when their own patients have a good outcome, healthcare wise, and a good experience, I think that's really powerful for practitioners just like us. So, and the same thing goes with whether it's a myotherapist or a physio or a different practitioner they might be seeing. Keeping their team of providers involved can be helpful in terms of building those networking relationships, and also when they've got a patient who comes in who has a similar problem, you start to come sort of front of mind.
No, absolutely. And my doctor refers to Marcus. So here we go. Wonderful. Is there any final comments from our awesome experts?
Get one, try it, and then get in touch with one of us, and we can take you through how we'd use it.
Perfect. That's it. And we'll send through that link, so how you can book in a one-on-one with James, Marcus, and Adam, and have a personal, small group CPD. Well, thank you so much. Thank you, James. Thank you, Marcus. Thank you, Adam. That was brilliant. And we went over time then, so you definitely deserve a rest after talking for so long. Or maybe a glass of wine and your legs up. And for everyone watching, thank you for joining us. And we'll make sure that we send an email through with all those links, and obviously the link to book that one-on-one as well. Thank you, everyone, and have an awesome evening.
Thanks everyone. Have a good night.
Thank you.
Great questions as well.
Yeah.
Very good questions, true. Thank you.
See ya.